rheumatology, currently working in Sri Ramachandra Medical College and Research Institute in our hospital and Apollo Children Hospital. He did his postgraduate training here and then got a super specialty training in pediatric rheumatology from United Kingdom. He'll be covering the session for the next half an hour. Over to you, Dr. Mahesh.
Thank you for the introduction. Where can I share the screen? Is it where's the
share content, sir? Can you click on the share content on the top? Is,
share screen. Yeah,
share screen, yes.
Yeah. It's visible now?
Yes, sir. We can see you, sir.
Okay. Well, good evening to you all. For the next half an hour, I'll be just quickly going very briefly through the rheumatology OSCE scenarios. First, I'll be talking a little bit about inflammatory conditions and non-inflammatory condition and a little bit of vasculitis, more common things that you see in practice. I'll first start with PGALS. PGALS stands for Pediatric Gait, Arms, Leg, and Spine. And this is actually the musculoskeletal examination in pediatrics in children. For the adult one, you call it just GALS. It's been included in the curriculum in Western countries for the last 20-25 years. We are yet to include it in the curriculum here in India. For DIPNB exams, musculoskeletal examination is part of your practical examinations. So when would you do a PGALS assessment in a child? Any child presenting with muscle, joint, or bone pain, a child who's unwell with fever, the pyrexia of unknown origin, not for every child who's walking into the clinic, but for a child who's been admitted to the ward and you don't know what the diagnosis is, you have to do a complete PGALS. A child coming in with an obvious limp, a child presenting with delay or a regression of motor milestones, and also in a clumsy child in the absence of other neurological diseases. This is mainly to look for features of hypermobility. And in children with chronic disease and in chronic disease and those which are associated with musculoskeletal presentations. For example, conditions like inflammatory bowel disease, cystic fibrosis, and so on. So just practical tips. That is when you suspect there's some inflammatory joint disease in a child, just because the child is not complaining of pain, it does not mean that there is no arthritis, because in very young children, they tend to present with loss of function rather than pain, because most of the inflammatory arthritis is insidious in onset. They sort of adjust to the pain and they present with loss of function. For example, like a child who was previously able to walk, who's now not able to walk, but still not complaining of pain. A toddler who's been playing and running around is refusing to walk in the morning, wants to be picked up. And then after some time, when the early morning stiffness settles down, then the child is happily walking around. These are all sort of symptoms that point towards a possible inflammatory joint disease. And we need to clearly probe for symptoms such as gelling. For example, after taking a child for a long ride in a car, then the child might have some stiffness or may refuse to walk, and that signifies joint stiffness. And also ask for recent deterioration in certain functions like handwriting skills, regression of motor milestones, and a child who was previously playing well, for example, a really athletic child now refusing to play, particularly in the mornings. So he appears like a lazy child who doesn't want to get out of bed, but that's because of the early morning stiffness. And any deterioration in behavior, that's recent deterioration in behavior, irritability or poor sleeping, all this points to an inflammatory joint disease. And when a patient is brought to the clinic with one particular joint, does they need to examine all the joints, not just the symptomatic one, but you need to examine all the asymptomatic ones too. The reason is that parents may think the child is limping because of problem in the knee, but the actual pathology may be lying in the hip joint. And also remember the red flags which could raise the possibility of infection, malignancy, or non-accidental injury. Any child presenting with joint symptoms and systemic manifestations like fever, malaise, or a systemic upset like reduced appetite, weight loss, or sweats. Think about other conditions like malignancies, particularly. And a child being born with fever, bone or joint pain, and a child who's got joint pain which is refractory, not responding to NSAIDs, and has got unremitting pain, and there is persistent night waking, and that is the sort of red flag for malignancies. There are also other non-pathological causes of night pain. For example, the most benign one, like growing pain, it causes night pain, but it's the most benign cause of night pain. And the other cause of night pain would be osteoid osteoma and chronic recurrent multifocal osteomyelitis. When there's incongruence between history and presentation, for example, a child is being brought in with not moving hands or legs and is having evidence of multiple fractures, and the parents is giving an inconsistent history, that should suggest a non-accidental injury or child abuse. And in pediatrics particularly, you need to remember what the normal variants are. So, for example, children, in young children, tiptoe walking or walking on the heels may be normal until a certain age. The presence of hypermobility is, for example, normal until like 5 years of age. And also look for any other dysmorphic features or short stature, which may point to an underlying storage disorder. And look for evidence of motor regression or delayed motor milestones. And if the child is being brought in with one particular, as I previously told, if there's any one particular abnormal joint, also look for abnormal joints elsewhere too. For example, if the child might be having a problem in the hip, but the presenting symptom might be in the knee, or it might even be in the ankle sometimes. So just a few things to differentiate between the most common conditions that you would see in practice. Obviously, the most common causes of pain, of joint pain you'll be seeing in clinic is growing pain. Growing pain is seen particularly in young children. They are very healthy, but the parents are the ones who are mostly concerned because they wake up the parents at night because of the pain. But a simple massage from the parents actually makes the child sleep again. And this is very characteristic of growing pain. And they're generally very well during the day. And they're growing well, they're thriving well children. And that is a typical feature of growing pains. The other common cause of growing pain is joint hypermobility. Joint hypermobility with benign musculoskeletal pain. And that we'll talk about a little later, how to look for it. The most other common conditions, pathological causes, the most common is post-streptococcal reactive arthritis, acute rheumatic fever, then JAA and leukemia. And how to differentiate between the four based on the symptoms. The onset is acute in reactive arthritis and acute rheumatic fever. And in JAA, it's often insidious, and leukemia also sometimes is insidious onset. As far as the age pattern, age group that is involved, in reactive arthritis, it's 8 to 14 years of age, 5 to 15 in acute rheumatic fever. JAA, depending on the type of arthritis, it's variable. In young children under 5, you would see systemic JAA and oligo-JAA being common. And in adolescents, you would see ankylosing spondylitis or enthesitis-related arthritis being more common. Leukemia, again, the under 5 is more common. So what type of joints are involved in these type of arthritis? In reactive arthritis, the large joints are mostly involved, and it presents an additional pattern. So there's one joint one day, and then after a few days, you can have another joint. And it tends to be persistent in those joints. Whereas in acute rheumatic fever, there is large joints involved, but there is migrating. There's a history of migrating arthritis. In JAA, it can involve either large or small joints, and they are often additional. First, they present with one particular joint, and then they can go on to involve more joints as time goes by. In leukemia, you can have large and small joint involvement. Nocturnal pain is only present only in leukemia, as I previously told, can also be present. Nocturnal pain can be present in growing pains, osteoid osteoma, and chronic recurrent multifocal osteomyelitis. Extra-articular manifestations, they are rare in post-reactive arthritis. And carditis and chorea are the other features, extra-articular features in rheumatic fever. And in JAA, particularly in systemic onset JAA, you can have other systemic manifestations like fever, lymphadenopathy, hepatosplenomegaly, and serositis. And uveitis is more common in under 5 oligoarticular type of arthritis. In leukemia, they're often seen extra-articular features. Axial involvement or spinal involvement is normally not seen in rheumatic fever. It may be seen in post-streptococcal reactive arthritis or JA and leukemia sometimes. And the response to aspirin is excellent in rheumatic fever, poor in reactive arthritis and leukemia, and variable in JA. And remember that this condition called Reiter's disease, which was a triad of conjunctivitis, urethritis, and arthritis, we don't call it anymore. They're all grouped under reactive arthritis. We don't call them Reiter's disease anymore. So when you're seeing a child with joint pain, you need to ask the following screening questions. This is part of PGALS. So does your child have any pain or stiffness in the joints, muscles, or back? Do you have any difficulty, or the child has any difficulty getting him or herself dressed without any help? And any problem going up or down stairs? These are 3 screening questions. So first, you observe the child standing from front, back, and sides. By doing this, you're looking at the posture and the habitus. You're looking for any skin rashes, which could suggest psoriasis, lupus, or vasculitis. Look for any obvious leg deformities. Look for leg length inequality. Check the leg lengths from the anterior superior leg spine to the medial malleolus on both sides. Look for the leg alignment for valgus varus deformities, scoliosis, any visible joint swelling or muscle wasting, or flat feet. Observe the child walking. Ask the child to walk on the heels and tiptoes. This is particularly to detect arthritis of the ankle and the midfoot arthritis. And by doing this, you're looking at the ankle, subtalar, mid-tarsal, and small joints of the feet, and also look at the foot posture, particularly looking for the presence of arches. And the flat feet may indicate the presence of hypermobility. Then ask the child to hold the hand out straight in front of him or her. And by doing this, you're checking the forward flexion of shoulders, elbow extension, wrist extension, and extension of the small joints of the fingers. Then ask them to turn the hands over and make a fist. By doing this, you're checking the wrist supination, elbow supination, and flexion of the small joints of the fingers. Then ask them to touch the tips of the fingers. And by doing this, you're checking the manual dexterity, which means the ease with which they're able to do these actions. And you're checking the coordination of the small joints of the fingers and thumbs. Then you squeeze the metacarpophalangeal joints. That's because they're sort of like invisible joints. The PAP and DAP are more visible, and so sometimes you're not able to easily visualize the MCP joints swelling. So you need to squeeze them and then look for tenderness. Then ask the child to put the hands together, palm to palm, and then the hands together, back to back. By doing this, you're checking the small joints of the fingers, wrist extension, and elbow flexion. Then ask them to reach up and touch the sky and look at the ceiling. By doing this, you're checking the elbow extension, wrist extension, shoulder abduction, and neck extension. Then ask the child to put the hands behind the neck. And by doing this, you're asking them to you're checking the shoulder abduction, external rotation of shoulders, and elbow flexion. Then ask them to try and touch the shoulders with their ears, and you're checking the C-spine lateral flexion. Then ask them to open their mouth and put 3 fingers, as the child's own fingers, into their mouth, and you're checking the TMJs, and also check for any deviation of the jaw movement at this time, temporomandibular joints. Then feel for effusion at the effusion at the knee by doing a patellar tap or a cross fluctuation. So you're looking for new effusions by doing this maneuver. Then check for active movement of the knees, flexion and extension, and feel for crepitus. You're checking the knee flexion and extension by doing this. Then the internal and external rotation of the hip, the spasm movement of the hip, and keep the knee flexed at 90 degrees while doing this. So you're checking the hip flexion and internal rotation. Then ask the child to bend forwards and touch the toes, and you're checking the forward flexion of the thoracolumbar spine, and you're also visually checking for any obvious scoliosis. Once you've done that, then you have to document your abnormal findings. So for example, you have a child with left knee pain, then you ask any pain, yes, left knee, problems with dressing, no difficulty, problems with walking, some difficulty in walking, and depending on which side you see the abnormality, you can put a tick. You put gait, arm, leg, spine, right and left, appearance and movement, and you write which is abnormal. So don't dictate the child and ask them to do maneuvers. You have to show them how to do it. And while checking the joints, look at the child's face while checking the joints to look for any obvious discomfort. Don't keep concentrating on the joints itself. and obviously do a complete screen all the time. Look for any obvious asymmetry and consider any clinical pattern. For example, a child presenting with hypermobility may have an underlying syndrome. And once you've done identified a abnormality in one particular joint, then you do pediatric regional examination of musculoskeletal system. That's PREMS. Here you do 4 things. You look, feel, move, and assess the function and measure. So you look for obvious things: swellings, rashes, psoriasis, rashes of psoriasis, vasculitis, lupus, and so on. Look for obvious muscle wasting, scars, leg length discrepancy, and then check for 4 Ds: deformities, dysmorphism, disproportions, and discomfort. And feeling, you feel the temperature. Look for obvious swelling and tenderness along the bones and joint line. Look at where the tenderness is. Is it there at the joint or along the bones? Because that will give you an indication whether you're dealing with a malignancy or an arthritis. A very hot joint is likely to be due to an underlying infection. And full range of movement should be done. Check for the active and passive movements. Note for any obvious asymmetry. And you can actually differentiate whether it's mild, moderate, or severe restriction of the joints, depending on what you see. Ideally, for the best way to do a function assessment is by doing by a physiotherapist. But you can also use your CNS examination to assess the power of muscles and for stability. And always measurement of the height, measure the height and also the limb length. So how do you examine the spine? Obviously, you're going to check with a child. The routine one, you would ask the child to stand and then bend and touch the toes and see if they're able to do it. Then for children, particularly with ankylosing spondylitis, you would need to do something called a modified Schober test. And here, what you would do is you ask the child to stand upright, and then you make, there's a sacral dimple on the either side. You make a mark on both sides and a mark in the central area like this. And then from there, you measure 10 centimeters above and then 5 centimeters below, and then make a mark 10 centimeters above and 5 centimeters below. And then you ask the child to bend forwards, and the area between this, that's 15 centimeter area, will then expand to 21 centimeters, and that is normal. If it is less than 5 centimeters extension, on bending, then that's abnormal. That means there's problem with the spine. This is just a 2-minute quick video on PGALs. So that's the end of video. So just going on to the next clinical situation. I told you about hypermobility already. This is a young boy who's presenting with pain in all the joints, and the typical history that you would get here in a child who's got non-inflammatory pain is this pain gets worse with activity, whereas in arthritic pain, the pain is worse in the mornings and it gets better with activity. If a child is presenting with joint pain, which is worse at the end of the day or worse with activity, then that is mostly due to a underlying hypermobility. So this is what this boy has. You can see the hyperextension of the knee joint. You can see how much he can bend the little finger, and you can see that he's able to do these maneuvers. So hypermobility. So there's something called Baton score to assess hypermobility. So you ask the child to dorsiflex the little finger backwards, and if it's more than 90 degrees, then you take it as one of the features of hypermobility, and then bend the thumb and touch the volar aspect of the forearm. And then you look for hyperextension at the knees and the elbows, which should be more than 10 degrees. And then ask the child to touch the floor without bending the knees. They should be able to touch the floor with the flat of their palms. And so you give points for each of them. So if there is 4 and more of 9, then you give them a score of, give them a diagnosis of hypermobility. So there's 1 each for each of those maneuvers for each side. That's both thumbs, little finger, and hyperextension of the knees, elbows, and able to do the maneuver with the thumb. And then there's 1 point for bending and touching the floor. So total 9. Then other example for hypermobility is a child who's got hypermobility, but who's obviously got syndromic features. And this is a child with obvious Marfan syndrome. You can see the big arm span, the arachnodactyly, and you can see the chest deformity. It's like a pectus carinatum, and you can see the obvious scoliosis. He's tilting to one side, and you can see some facial abnormalities with crowding of the teeth. So the skeletal system abnormalities that you would see in Marfan's pectus carinatum, pectus excavatum, reduced upper to lower segment ratio or arm span to height ratio more than 1.5, scoliosis of more than 20 degrees or spondylosis, reduced extension of the elbows, medial displacement of the medial malleolus causing pes planus, and general joint hypermobility. And the most 2 important clinical signs that you need to look for is a positive, the thumb sign and the wrist sign. Therefore, asking them to fold the thumb into the closed fist. And if the test is positive, that means the thumb tip extends from the palm of the hand. That is the thumb sign. And the wrist sign, asking them to grip the wrist with the opposite hand. And if the thumb and the 5th finger of the hand overlaps each other, then this represents the wrist sign. So they've got names as well, Steinberg and Walker Murdoch sign, but it's easier to remember as thumb and wrist sign. Look for other facial abnormalities, high arch palate with dental crowding, facial appearance, dolichocephaly, malar hypoplasia, enophthalmos, retrognathia, and downslanting palpebral fissures, ectopia lentis in the eyes, cardiovascular abnormalities, dilatation of the ascending aorta with or without aortic regurgitation, dissection of the ascending aorta, mitral valve prolapse with or without regurgitation, dilatation of the main pulmonary artery, and pulmonary problems could be spontaneous pneumothorax and apical bleb, and skin and integument abnormalities, lumbosacral duroactasia, stretch marks, look for obvious stretch marks, and recurrent or incisional hernia. Then last case is just a very easy case, which you're probably seeing on a day-to-day basis. A 3-year-old presenting with fever more than 6 days, and who's got this appearance with red eyes, red mouth, and a miserable child, irritable child. Child is as shown in the picture. I don't think I have to tell you the diagnosis. It's already there. It's Kawasaki disease, obviously, and I'm sure all of you know the criteria for Kawasaki disease. And basically, it's fever more than 5 days with 4 of the following. That's conjunctivitis, non-purulent conjunctivitis, changes of the lips and oral cavity, cervical lymphadenopathy, polymorphous exanthem, and changes in the peripheral extremities. And when you have less than 4, then you call it a less than 4 features, you call it as incomplete Kawasaki. And they were present with some other abnormal finding. For example, a child presenting with a UTI and has got a coronary aneurysm, or presenting with hepatitis or amoebic abscess has got coronary aneurysm, then you would call it as an atypical Kawasaki. So sort of rashes that you would see in Kawasaki. So apart from the ones mentioned, then again, skin peeling, obviously a late feature of Kawasaki. Apart from the ones that actually seen as part of the criteria, there are certain other clinical features that are highly suggestive of Kawasaki or almost indicates Kawasaki and nothing else, but they are not part of the criteria. For example, a child presenting with PUO and reactivation of the BCG scar, a child presenting with PUO and perianal excoriation, a child presenting with PUO and ultrasound showing hydrops of gallbladder, a child presenting with PUO and showing sterile pyuria. And those sort of features are particularly important when you see young children, particularly less than 1 year, presenting with PUO on those features. There are also a lot of nail abnormalities that have been discovered in Kawasaki, and they are also highly suggestive of Kawasaki's. For example, orange-brown chromonachia. Of all other features, probably this is probably relatively earlier sign about which can happen within 5 to 10 days of the start of the disease. You can see those orange, red lines here. And then onychometasis or separation of the nail from the nail matrix. Again, this is a relatively late sign. Other peripheral features include leukonachia striata and Buse lines. Again, they're all late features. They almost look similar to each other. The only thing is, in leukonachia striata, there is no indentation of the nails. And here, in Buse lines, you can have indentation. I will not talk much about the treatment, as you all know about it. I just want to show you some clinical pictures. And I'm happy to take any questions. If you wish, you can email me. And good luck to you all.
Thank you, sir. It was an excellent presentation, emphasizing the importance of the rheumatological examination, which most of the time it's not being done. So it's good that you have emphasized about the PGALs and also about the common rheumatological conditions based on which lots of OSCEs will be coming up and the PGs will be able to answer. Not many questions, sir, only a couple of questions. One question is still, what age can growing pain occur? Is there any particular age till which and beyond which we can't think about?
Yeah, we did a survey on musculoskeletal examination in school children. Actually, no age is exempt from growing pain. That is the truth. It is only lesser as they get older, but it's very common in the like under fives.
Okay.
Under fives, but it does 5 to 10 in school-going children also. You have noticed it, but we have noticed that that survey that as they get older and it's less. For example, in the adolescent age group, it is probably completely absent. But we have seen in up to 14, we have seen. We did a PGALS survey in school-going children. And we asked for screening questions, and that's how we found it.
Okay, and any particular reason for the growing pain, sir, or any being reported as cause?
There are lots of theories. I don't know which one is correct, but I don't think I can't give a proper explanation for that. But all we can say is that completely. Some people used to say previously it's growing bones and all. It's not got, though we call it growing pains, it's not got nothing to do with growing bones. It's not like because it's the bone is growing, they've got growing pains. It's not like that. Okay, but that's how we tell the parents. Yes. That's the thing that we used to tell the parents.
Okay, thank you, sir. And one more question. Can you just explain how to check patellar tap? I think one of the videos showed. Can you just briefly tell the position and how to do the patellar tap?
Actually, it's more easy if I have a patient. I can't demonstrate it.
Yes, sir.
Actually, it's like doing the same orthopedic. The best thing is to actually, when you're looking at if they have an effusion, is to milk the fluid down. If you have the knee joint, for example, I'm just showing this, like this bottle here. You just milk the fluid down like this. And then in the particular place where when the fluid is completely milked down into the joint, you can then feel it's easier to check for the tap. But I really need a patient to demonstrate. It's better to milk the fluid down into the joint from the top and then check for patellar tap. Just press the patella.
Patella anterior posterior.
If you go down, hit the thing, and then come back and it hits your palm again. So, and it's almost like a balloon. Once there's fluid, it's almost like a little balloon. It gives like a balloon-like feel.
That's it, sir. Thank you, sir. No more questions, sir. Thank you very much for your time and sharing your experience.